back in the early half of the 20th century, the 1930s, 40s, into the 50s, there was an outbreak of a viral disease known as poliomyelitis. Polio's been around for thousands of years. Okay, this isn't anything new. The problem is it was hitting the United States really hard. And the problem beyond that, what added another layer to the horror that we know of as polio, is that polio seems to strike young children the hardest. If you were to pause this lecture or just, switch over to another window in Google, and if you Google polio, the pictures it's going to pop up is wards of children. Dozens and dozens of children in a room, all of them in iron lungs. That, for the older generations right now here in the US and in Europe, in many places around the world, that is the view they have in their mind's eye of polio. Children being struck down, children being sentenced to a life in an iron lung, a machine that uses positive, negative pressure to expand and push down on somebody's chest, to force air in, pull air in, force air out of their chest to keep them breathing. That is the neuromuscular paralysis that we associate with polio. There has been, over the past 3 decades or so, there has been a big push to add polio to that too short of a list of diseases that we are mobilizing against. We've gotten rid of smallpox, now let's go after polio. Now here in the US, we have the vaccines that we vaccinate, all children. Anybody who immigrates here, we inoculate them also. But we have to keep in mind, polio is still endemic throughout the world. There have been big pushes. Countries have gone through and are pushing as much as possible to vaccinate as many people as possible. The idea is if we get enough people vaccinated, we can get herd immunity throughout the human population. Polio will go the way of smallpox and will just be a scary story we tell to small children. Poliomyelitis is the clinical term for this disease. In the short term, it's a mild viremia. Aches, pains, things like that are very reminiscent of the flu. A lot of times people, it's so mild, they're actually, almost asymptomatic. Slight fever, slight headache, nausea, sore throat. The myalgia, that's a little bit of tingling. Again, really bad, allergies, or mild case of the flu. I've got a cold. And then people just shrug it off. They get better. They were exposed. They had a viral infection, and then it resolved. That's the majority of people. majority of people out there in the world who get exposed, especially before the vaccines, that's what happened. They had polio and they just never knew it. For a small percentage of people who get exposed, get infected, the viremia will continue. It will progress. So instead of the, slight cold, slight flu-like symptoms, it will progress. It won't resolve in a few days. It'll continue and continue, a week or more. And then new symptoms start to occur. We see that the virus will actually begin infecting the cells of the meninges. For some people, it will pass through meninges. When I say pass through, keep in mind it doesn't just flow through it, like it's not there. The virus will infect cells of the meninges. One goes in, dozens, hundreds, thousands come out, and they spread to neighboring and to neighboring and to neighboring and so on and so forth. So that's how it passes through layer upon layer upon layer until it hits the central nervous system. It is neurotropic. The virus seems to target motor neurons. Less specifically, spinal ganglia, cranial nerves, are, secondary targets. But it seems to infect at a higher rate, at a higher degree, motor neurons. The invasion of the motor neurons will begin to impede neuron function. The depolarization that needs to occur for the impulse to be passed down a motor neuron will no longer happen. It'll slowly begin to ebb. The ability will slowly ebb and go away, and at some point it will stop. When it stops, you now have paralysis. This is the paralytic disease we think about when we see in our minds the people in the iron lungs. The inhibition of the motor neurons to function, depending upon where in the spinal cord, where at the spinal cord brain junction, that these neurons are infected, that the impulse stops at, will determine where the paralysis begins. High enough up, they'll lose everything from the arms down. Lower down in the spinal cord means, it's from chest down or waist down. We also see what is referred to as bulbar poliomyelitis. This is where the infection seems to center around the brain stem. The brain actually becomes the site of the infection, the center where the infection seems to stem from. Here we begin to see that it's actually brain functions that are affected the most. Yes, there will still be paralysis, but patients that are suffering just from the paralytic disease still have higher brain function. Okay? They still are aware. They are still self-aware. Those patients that it has progressed to what is the bulbar, here they start to see loss of higher brain functions. because the cranial nerves are beginning to be affected, and it will lead to, from what I've read, mental issues, as well as the full-on, body control issues. Keep in mind, once the paralysis sets in, the muscles stop being used, there will be atrophy, so that the muscles will start to literally shrink and shrivel away. Once it hits a certain point, the atrophied muscles, there's really not much coming back. If you were to come up with some way to overcome the break in the neural pathway for the motor neurons, the muscles have degraded so far that there's no rebuilding them. The coronavirus, or Coronaviridae, is the family for that poliomyelitis is in. It's an enterovirus. An enterovirus, just like enterobacteria, are bacteria that are passed or are associated with the gastrointestinal system. Since it's an enterovirus, this means it is a fecal-oral spread, person to person. What we found through studies is that the normal route for the spread of polio is through fecally contaminated water or foods. Person will ingest contaminated water, contaminated food. The polio will be able to bind to and force its uptake by mucosal cells. The oropharynx is where the mouth does, the tube of your mouth does the bend to your throat. That is the oropharynx region. So starting basically at your throat down to your intestines. All of these cells have the correct receptors that poliovirus has the ability to hijack. One goes in, dozens, hundreds, thousands come out. The infected patient will be shedding the viruses in their feces. So even if they are asymptomatic, or they just have that mild version where they think they have the flu or just really bad allergies for a while, they are shedding the virus. So as I stated, as I began this lecture, the 20th century, the early half of the 20th century, saw a rather large expansion in the numbers. Not to say hasn't always been there, but there are so many other diseases that were outcompeting polio when it came to causing issues in human society. Cholera and things like that. So that, you know, we were seeing more issues, more deaths due to diseases like cholera than we were, you know, paralysis due to polio. Something changed. How society was being run, the fact that we were becoming more urban, I think it is probably. More city waters, more well waters that were becoming contaminated as people spread out and they weren't watching how they were taking care of their sewage. If somebody in a modern day hospital, modern day clinical setting presents with polio, there's really not much that can be done, because once the symptoms of polio start to become more pronounced, the disease has already progressed to the point that the central nervous system is being infected. So if we're going from a clinician standpoint, it's basically alleviate the pain, any suffering. Supportive care here is basically what you can do. During the acute phase, muscle spasms, headache. This is going to be due to the central nervous system being hit, the meninges, the central nervous system, and the inflammatory response hitting them. As it progresses, you'll begin, in the clinical setting, you begin to see the patients either losing control of motor functions, or they're not able to, how do I say this? It's not going to be good today, complete loss tomorrow. It's going to be this slow progression. Hands are going to be wobbly. They're having trouble controlling arm movements, leg movements. And it's going to progress and get worse day by day as more damage is being done to the central nervous system. Best thing to do is prevention. We now have 2 really good vaccines. So vaccinate early in life as possible. This is going to be one of the early infancy vaccinations, because even infants can get hit. For adults, they're also recommending boosters if you're going to be traveling to an area where this is still endemic, this is still considered a problem. Middle East, parts of Africa, parts of Asia, this is still a problem. Mid-50s, 1954, Jonas Salk came up with the first vaccine, his inactivated poliovirus. He heated and chemically inactivated poliovirus, and then started injecting people. That was the first vaccine. It worked. It wasn't perfect. 2 problems. It wasn't 100%. What it mounted was a B cell, an antibody response. It did not involve T cells. So since the T cells are the chief white blood cells that defend against viral infections. B cells make the antibodies, which is great against toxins, it's great against bacteria, and it's limited use again as an antiviral. Well, Salk's vaccine worked, okay? It wasn't perfect. And the second downside to it, it's an injection. You have to go and you have to inject people over, multiple injections over time. You have to have multiple doses. And you have to go through person by person, everyone. That's the main problem that they had with it in the clinical settings. When it came to epidemiology, when it came to public health, the multiple doses, meaning an injection for each dose, and you have to space those out over days, weeks, months. Sabin, in the 60s, was able to genetically modify polio. So now it was a milder infection. So everybody who got the Sabin vaccine, they would get that mild infection. Ooh, it feels like I have a cold. Ooh, I might have the flu, that type of infection. And Sabin's was an oral vaccine. So basically a couple of drops on the tongue, come back months, a year or so later, do it again. You could sit there with one vial and vaccinate an entire village, vaccinate an entire neighborhood within minutes. Just have everybody line up, a couple of drops on everybody's tongue, and move on to the next town. Now, there were problems. There are problems with Sabin's. What we have found is that while the Sabin polio vaccine has been attenuated due to genetic modification, in some individuals, very, very low sub percentage of individuals vaccinated with the Sabin oral vaccine, the virus, the attenuated virus, will mutate and it will revert back to its full disease-causing form. So you'll end up with children who get polio, and they got the polio not from fecally contaminated water or food, but it was due to the vaccine itself. So you have a problem. So it's 6 of one, half dozen of another. The Salk, which kind of works, I mean, it's not perfect, but it takes multiple injections, multiple doses over time. Or the Sabin, which was quick, down and dirty, may, for some people, I think they're saying that it just, one dose is all it took. But for some people, it reverts. It may end up causing them to have polio. And here's the problem. It's not that they get polio immediately after the vaccine. The vaccine attenuated virus becomes latent, and it could be years or decades later that it causes the polio disease.